live talk show. We all know अच्छा जीवन जीने के लिए अच्छी सेहत का होना बहुत ज़रूरी है. So here we are to share some information with our special guest जो आपको बताएंगे कि अच्छी सेहत रखने के लिए क्या-क्या करना ज़रूरी है. But before we start our show, I would like to invite my co-host, Dr. M.S. Kanwar. He is Senior Consultant and Advisor in Department of Respiratory Medicine, Critical and Sleep Medicine at Indus Apollo Hospital, Delhi, one of the best hospitals in India. Welcome to the show, Dr. Kanwar.
Thank you very much, Rashmi. It's been a little break. We are meeting up again and starting our talk shows. Hopefully, will be more regular from this week and next week onwards. Today, we have a very eminent person with us, Professor Anant Mohan. He is head of the Department of Pulmonary Critical Care and Sleep Medicine on the Institute of Medical Sciences, New Delhi. And Professor Anant has been on our web series, on our symposium as a very active participant. And I'm glad, Professor Anant, you could find time. It's a bit late night in India. In UK, it is 5 o'clock right now. And Rashmi, you should be about 11:30 or what?
Yeah, it's around 12ish.
All right. The subject today that we are going to discuss is something which affects so many households. Somebody or the other in the family or near or dear ones does have somebody in the family as a child or an older person suffering from bronchial asthma. And asthma is often in the early stages misdiagnosed, rather loosely applied as a term for bronchitis or allergies, but not specifically given the right name in most cases for sometimes years together. And that leads to delay in the proper treatment plan for these patients. And Professor Anant would throw light on a lot of these things. And we'll start with Professor Anant. I hope you're enjoying this show. It's the first time you have been here, but I would like to have you around again some other time too.
Yeah, sure. Thank you very much, and thank you for giving me the opportunity. Really, really happy to be here.
Thanks. Let's talk about the global prevalence in India. What do you think is the roughly approximate prevalence of the disease? And worldwide, there are some countries like Australia, for example, Brazil, even UK, which have a very high prevalence. But in India, the reports have been very varied. Some studies have shown a higher number. Some studies have shown a smaller number. But my general feeling is that the numbers are on the higher side. What do you think about that?
Yes, that's true. So, if you talk about the prevalence of asthma in the country, again, there is no national database of asthma in our country. Unfortunately, there have been one or two big kind of field kind of studies. One was from PGI. One was the InSearch study, which was published more than a decade ago. Then there have been and it also depends upon where it has been conducted, whether it has been conducted in the field, whether it has been conducted in a hospital, single hospital, what level of hospital. So that is, and whether it has been conducted in an urban setup or in a rural setup. So a lot of things matter when we talk about a disease like asthma, because asthma is affected by so many other extraneous factors, not just the intrinsic factors, but the external factors. Hence, there is a kind of variation as far as the prevalence of asthma is concerned. You are right about that. Broadly speaking, in the field study that was done, it was somewhere around 2 to 3 percent kind of a thing among the high risk population, that was among the children up to the adolescents. So again, among that, this is almost, I think, about 10 to 12 years back. And then there have been reports from many other centers, local centers in the country, where they have reported a variation from 2 to 5% in the children group, again depending upon the rural, urban, field study, hospital-based study. Also depends upon what is the tool which was used to diagnose it. If it was only based on some questions, or whether they use some other technique like a spirometry or a pulmonary function test. Hence, this variation is there. Unfortunately, we do not have a national database, but I think that would be the actual way to talk about the prevalence of a country per se.
Yeah. Uh, if, Sorry, Rashmi, you were saying something?
I just had one question which was commonly asked by everyone, that asthma के बारे में ये कहते हैं कि it cannot be cured but it can be controlled. Is it true?
Well, again, it depends upon the cause. If it is precipitated by some external factor, then on removal of that factor, then person can be like, what you call as cure. Then he will not have those symptoms again. Whereas if it is a kind of intrinsic asthma in which it is part of his own genetic makeup, maybe his family history, or these kind of things which are putting him at risk, then yes, technically speaking, he will not be cured of asthma and he will be controlled. So, but in those settings, again, can be kind of said at an equal and par with cure, provided he is not, exposed to factors which can precipitate asthma. So, yes, in a way, technically, you may be right that in many situations, we may not 100% cure, we may control with or without medications, but sometimes, if it is a less severe form, it is more because of exposure to some particular agent. Then, on removal of that agent, it may be possible to kind of keep him asthma free.
Thank you.
Professor Anand, what are the common agents? You're talking about agents, strong smells, noxious agents, and pollens and all that. So, what do you classify as the more common of these agents which are affecting people around the globe?
Well, again, all the factors which can precipitate asthma can be again classified by various means. They can classify based on their say chemical component, for example, organic versus non-organic. That is one way of classifying, but that will be a too scientific a way to classify. One can classify say as infective versus non-infective causes. So one, of course, infections we also know can precipitate or even cause asthma when the repeated infections hit a person at some stage who may be susceptible. That is one. But among the non-infective are the more important, and it is also known asthma is very closely linked to to allergy and allergic tendency. So allergy and asthma many times go hand in hand. Not to say that all allergy people having allergies are having asthma. No, it is probably more true the other way around. Food, for example, food items, there are food allergy is very common, and many times this food allergy may also precipitate a person into an asthma attack if he is already predisposed. Then of course there are the environmental factors like you mentioned. It is the pollen, other environmental toxins, the particles which are moving around, which can get inhaled, can get deposited inside the deep part of the lungs and the airway tract, and there they cause a kind of an inflammation. And basically asthma is an inflammatory disease, and when they cause inflammation, any agent, when any noxious or a toxic agent enters through our airways and deposits into the distal part of the airway, it causes inflammation. Long term inflammation causes narrowing of the airways, and all this then subsequently leads to the symptoms which are characteristic of asthma.
Yeah. When do you think that the parents should get alerted in the case of young children? What kind of symptoms they come up with that the parents should not ignore?
Well, if we start from very early in life, probably very subtle signs can be there. For example, a person is a child is not able to take proper breastfeed. Maybe he becomes tired very easily. He leaves the feed. He becomes blue when he is taking milk. So these are some subtle signs which should alert a mother that probably he is becoming short of breath while sucking. Or if he becomes a little older, then he is not able to run, not able to play as well as his other friends are able to play. He becomes tired faster, he becomes short of breath faster, or again if he becomes blue. So these are the things which one has to be alerted during the toddler or the infant or the school age times. And then of course, if he is getting infections very frequently, repeated infections, then one has to be alerted whether there is anything inside which is causing the infections. If he is having repeated attacks of sneezing, rhinitis, running nose, sinusitis attacks, or even upper airway infections, if he's having repeated attacks of ear infections, all these are signs that probably there is something wrong in his either his immunity or his upper airways, which is not necessarily always asthma, but many times they go on to develop asthma. So he should undergo, or rather, the parents should get the child checked up regularly in any of these situations. And then, as he becomes older, then he may or she may start having that whistling kind of a sound, gurgling kind of a sound in the breath, maybe even at sleep, or when there is a sudden episode of cold, or if he takes something cold. So there are so many signs which one can, have to see, which one can occur. And then, of course, there are the florid signs of wheezing, the shortness of breath, a feeling of chest tightness. When he becomes slightly older, then one may be able to tell the parent all those things.
Yeah, perfectly. Rashmi, while I have more questions, you have something on your mind or any questions that popped up?
Nothing. One of our viewers have a question that they have carpet flooring in their house and their son is suffering from asthma. So, can it be a problem for their son or?
Yeah, I think so. Definitely, it can be a problem. For example, so all these are house dust mites. For example, like I said, asthma and allergy are quite closely interlinked. Many times we tend to confuse every allergy with asthma. That is not the case, but definitely there is a link between the two. And house dust mite and other items in the house, in the household, all these are known causes of allergic symptoms, which may lead on to asthma or even other conditions, for example, hypersensitivity, pneumonitis, etc., which is slightly more technical terms. So one has to be careful. If there is an asthmatic child at home, then ideally one should stay away from kind of dusty things. So like all the old carpets, and even, for example, be careful of pets. Sometimes close
Oh,
contact with pets can precipitate asthma. That is a very important factor that many times we tend to ignore. Then anything that happens in the house, for example, a whitewash happening in the house, a simple whitewashing may precipitate asthma in the person because all the fumes is coming. There is a lot of dust. So many things are there. Gardening, if he is fond of gardening outside, then there may be something over there which may cause. So in the house and around the house also are many things that one has to be very careful about.
Yeah, perfectly. Rashmi, sometimes this, even perfumes, strong perfumes can initiate the allergic symptoms and the wheezing. Even the cooking, or kitchen smells, the kind of cooking we do in India or Indians do abroad. So that is quite a smelly area. So that can also precipitate. So paint, fresh paint, all these things can lead to asthma because of those fine vapors that you tend to inhale, and they can react adversely. Um, and how do you diagnose these patients, Dr. Anand? I mean, what do you do as a definitive test to make sure that the child or the adult is really having a spasmodic disease, whereby the spasm is happening, and well, and then you would like to see whether the spasm is relieved completely with the treatment nebulizer, for example, or partially, or it's an immediate reaction or a slow reaction that would improve over a week or two. So how do you actually look at those things?
Well, asthma primarily is a clinical diagnosis, and one has to have a compatible history first of all, like we have been talking in the last 5-10 minutes. A compatible history based upon the person's activities, whether he is having shortness of breath, chest tightness, wheezing. Is there anything that is precipitating his symptoms? We have to go into the details of that. Or sometimes there may be an entity called as cough variant asthma, where shortness of breath is not the primary symptom, it is the cough which is the primary symptom, and a person keeps on coughing, and there is extensive spasmodic cough, and that is what worries him. And he just says, "Ki, I'm just coughing all the time. I'm not having any shortness of breath, but when I start coughing, I just can't stop, and it may happen 1 to 2 bouts a day, which can be very, very distressing." So this is also something which may happen. So apart from the symptoms and all the history of allergies and everything that we have talked about, when we come to the diagnostic modalities, well, the main diagnostic modality will remain as spirometry. Spirometry is a device in which we ask the person to breathe in and then forcefully out into a tube, and that into a machine, and that machine then does measurements of the volume of the lungs and the rate at which the person is breathing in and out, especially the rate at which he is breathing out. And then based on certain equations, values are generated, a graph is generated, and based on that we decide whether a person is having a difficulty in forcefully expiring the air out or not, which is the one of the hallmarks of an obstructive airway disease such as asthma. Then we give him a inhaler, because the inhalers are the mainstay of treatment of these diseases. Inhaler is given to that person at that point of time. He's asked to take 2 puffs, and after 20 minutes again that same maneuver is performed, and we try to see whether this inhaler improves his parameters. Now if it does, this is one of the most important or most reliable test. It is called a reversibility test, to tell that this is we are dealing with a reversible obstruction, which setting in the appropriate setting is most likely to be asthma. So this is one very important test. Then there are many other tests. For example, testing a person for allergies. There are blood tests available. There are skin tests available to see whether he's having concomitant allergies or not. One can do an X-ray of the chest. One can do X-ray of the paranasal sinuses to rule out allergies in the sinus areas. So these are all ancillary investigations which can be done along with all of these.
Okay. And Dr. Mohan, one of our viewer has a question that is it contagious? Like,
No, no, no. Asthma is not a contagious disease. No, there is definitely a genetic predisposition to it, and it can run in families. That is true, but it is not contagious like an infection. So it is not that you can spread asthma from one person to the other. No, it's not like that.
yeah, because she has a question like her husband doesn't allow her kids to go in their grandparents' room like that because they feel
Uh,
scared.
so who's the asthmatic here?
Grandparents.
So, okay. No, but I think that should not be a concern. Asthma should not be a concern for social interaction. There is no transmissibility of this disease. A person may be having any infection, asthmatic person may be having an infection that one feels can be transmitted to others. Viral infections are very common in asthmatics, but asthma per se is not transmissible or contagious.
So, is there any
Yeah.
specific age for that when you can have it or it can happen at any time?
No, children are more predisposed to have asthma, so that is why, and it can start at any age, but mostly it is the preschool and the school-going children who are most likely to have asthma. The prevalence of asthma is highest in this age group, and the prevalence gradually reduces as the age increases, adolescents, and in the adult age, gradually it will reduce. More often than not, a small percentage do have persistent asthma even into adulthood, and then at one point of time we call it as a remodeled asthma, where it kind of becomes something which is there to stay, and they may have to kind of live with inhalers for a very long time. But the primary disease, it is primarily a disease of the young.
Okay.
Yeah, sometimes it's a late onset asthma. Could be starting for the first time in their 30s and 40s even. So, how often do you see late onset or in what we call intrinsic sort of asthma? So, how often do you see that?
We do see it, but yes, like you said, it is uncommon, relatively uncommon. I would say maybe 10 to 15% as a rough estimate of all asthmatics probably would be getting diagnosed at that age. Now, again, it becomes difficult to say whether they're actually late onset or whether they are not recognizing their symptoms early on in life. So when we delve deeper into the history, then they sometimes come out, okay, yes, I did have some problem in childhood as well. It may be of a different nature. It may not be the typical symptom, but they had some problem. Maybe it got okay for a couple of years. So there are symptom-free periods also. Asthma has an episodic disease. It has seasonal variation also. But sometimes it may be absolutely, the person may be absolutely okay for 1 year, 2 years, 3 years, and suddenly something may happen to cause a precipitating, again, an acute exacerbation. Hence, sometimes people don't remember what happened in their childhood, and when they have a manifestation 25, 30 years of age, then they come. So that may be one thing, but yes, around 10 to 15% probably would be getting diagnosed little later in life, like 25, 30 years onwards.
Yeah. Let's talk also about the treatment. What is your usual treatment plan in these cases?
Well, treatment is dependent upon two things. One, the degree of symptoms and the degree of disability of his activities of daily living, how much it hampers his activities of daily living. And secondly, on the severity of disease based on the spirometry. Now, mostly if the person is having a bad spirometry, he's also having quite a significant symptoms. The treatment of choice in asthma remains the inhaler therapy, and now it depends upon what type of inhaler, what level and what dose of inhaler we give. But usually it is an anti-inflammatory therapy, because asthma is an inflammatory disease. So steroid inhalers are the mainstay of therapy for asthma per se. Now there are several of them available around, so hardly much to choose which one over the other. I mean, all of them are probably almost equally as good when really don't have much to choose between the type of steroid inhalers, but that would be most important. And they have to be administered in the proper dose with the proper technique for a proper duration of time. Sometimes, if a person is having very mild symptoms for a very short duration, he may get away with using inhalers for maybe just even a week or two, and then he can leave it, and then he'll be fine for the rest of the year or even more. But sometimes, for more severe symptoms, we may need to give it for several weeks to months. And if that doesn't control, some people may need to take it even on a regular basis. Then, depending upon the symptoms, we may increase the dose, we may add some other medicine to the inhaler, and then see how it goes.
Yeah, yeah. In some cases who are more severe, we do take the help of things like montelukast and theophylline, and sometimes in chronic severe asthma, who are perennial type, we also take the help of ipratropium bromide as an inhaler, which normally we give in chronic bronchitis COPD patients. So all these things can be given depending on the severity of the disease. Some of these patients can even land up in the emergency and sometimes even in the ICU. So, what is your plan when they are in a distress, in severe uh, respiratory distress, breathing difficulty? Their even oxygen is getting difficult to maintain, so they have to put on oxygen. We do their tests, blood gases, and all those things. Put them on drip, monofilin drips, and all those things. And sometimes we even have to give them the support of positive pressure breathing in those cases where the respiratory muscles are actually getting fatigued. So, there, uh, what what do you have to say about such a patient landing up in the emergency, not responding promptly to the treatment, and then even moving on to the ICU? And how do you handle that?
Well, actually, the same way that you just mentioned, actually. So when a person comes, then we have to give him repeated doses of the inhaled therapy, which may be by a nebulizer or by a meter dose inhaler with a spacer. We have to give it, say, frequently every 20 to 25 minutes, at least 3 or 4 times. We will have to give steroids either by tablets or by the intravenous route also at that point of time. So these two again form the crux of the therapy, along with oxygen, of course. Oxygen is of paramount importance, because basically these people are hypoxic and oxygen deficient. But if that doesn't work, then we will have to go, like you said, for other modalities. We will have to go for pushing the air in by means of a positive pressure ventilator. We may have to go in with, now in today's time, we may have to go in for the HFNC, the high frequency nasal cannula also, if we want to deliver oxygen at a higher flow rate and a higher oxygen concentration. If they do not improve even then, and then we give all the aminophylline and the deriphyllin drips that you talked about, and sometimes people have used magnesium in this kind of a situation as well sometimes. But if that doesn't work, then ultimately if the person kind of still remains in respiratory failure, the only option is to put him on a ventilator. And at this point of time, we have to put him on a ventilator and then treat him in the ICU like any other patient on a ventilator, give him appropriate ventilatory care. Fortunately, unlike the other chronic bronchitis type disease, most patients with bronchial asthma do come out. So if they are picked up in the right time, picked up early enough, then they do come out of this situation, because it's more of a reversible disease. So, but this is the approach. In this, one very important approach would be a self to teach the patient self care. That is, at home, if they experience some increased symptoms, they should know how to handle that to some extent. At least they should be able to increase the dose of the inhalers. They should be able to maybe even take one shot of oral steroids if required at the appropriate time before rushing to the doctor. This is not to say that they should start self medicating, but at least they should be knowing how to recognize the symptoms of an acute exacerbation, and at least taking the basic initial steps for that, and then go and seek medical advice, so that they don't present to the hospital so late that it is beyond repair.
Dr. Mohan, if asthma patient is smoking, how bad it can be?
Well, definitely, it's not good at all. It's smoking also causes inflammation of the airways. Asthma itself is an inflammatory disease of the airways. So you can imagine, when he's actively smoking, both of them compound together, and obviously the problem is going to get doubly worse. They develop into a kind of a more chronic problems faster. The disease progresses faster. They may go into a irreversible stage faster, and if they develop any kind of acute exacerbation, the mortality is higher. The chances that they will recover and respond to the standard therapy becomes less. So basically, it's bad. It's pretty bad. It's a
Yeah,
bad combo.
one of our viewer wanted to ask, her husband had smoking habit, but he switched to vape. So is it okay or is it harmful too?
He switched to what? Sorry.
Vape.
Vape, vape.
Vape.
Oh, well, again, this again is a topic in which there is a lot of debate whether vaping is how good or how bad, whether we should encourage the use of vaping as a substitute for active smoking. So I think over there in the West, it's a pretty hot topic. Fortunately, in
Yeah.
India, they have kind of put a blanket ban on all these kind of things. So that is why we have not really faced this problem to that extent. Now, I would just say that, smoking in any form is bad. So with these electronic cigarettes and all, they and some studies have shown that they help in the person to quit, but not always, and sometimes they may have rebound effects as well. I think it is too early to, or a little difficult to advocate vaping in place of smoking. One just has to quit
Yeah.
by some way or the other. I think that would be the simplest way to go.
And vaping is not entirely safe either, anyway.
Yeah.
Um, Finally, coming to a state where the patient can be very severe also and chronic also, and is also on long-term oral steroids. So sometimes the dose cannot be reduced the way you want. You want the patient to be, if he has to be on long-term steroid therapy, oral steroid therapy, you would want it to be as little as possible. But sometimes the moment you reduce the dose, the symptoms increase. Do you have some newer immunomodulatory drugs where such people could be helped?
Yes, we do have some of them. So that is where the scientific terminology of phenotyping of asthma is now coming into vogue. That is, asthma can be classified into two or three different types, and now there are several biological type agents which are available in the market, which can be used typically for this profile of patient that you are referring to. The ones who are severe, the ones who are not getting controlled after maximum doses of the standard therapy. That includes high dose of inhaled steroids, high dose of all inhalers together, plus even maybe oral steroids to some extent, even if that is to be given a long time, patient is not improving. So based on certain parameters, certain blood parameters like eosinophil count, etc., one can now kind of decide that this person may be a candidate for that particular biological agent which targets that particular profile of that particular inflammatory marker or that particular agent in the blood which is likely to be causing his problems. So biologicals are now available, they are injectable, they are expensive slightly, in fact quite expensive actually, but yes, they are an option for this small subset of difficult to treat or difficult to control asthma. So they can be administered. Some are 2 weekly, some are on a 4 weekly basis. They are mostly all injectable medicines, and they have been tested, and some results have been pretty promising in some subset of patients in whom they may benefit. And the patient in those patients who benefit, we may be able to stop the steroids and give them some symptomatic relief in the long run.
Perfect. Rashmi, we have by and large, covered the subject fairly well. And you have any more callers or any more questions at your end?
This is all, and of course, Dr. Mohan has covered so many things in such a short period. I'll say it was amazing to have him with us today. It was really very informative, Dr. Kanwar, and our viewers are very happy to see Dr. Mohan with us today.
Thank you. Thank you.
Absolutely. Absolutely. So with this, we come to an end. To sum it up, asthma is something which should not be taken lightly, and the parents in children should be alert to the possibility if the child is having cough, chronic cough, or huffing and puffing while doing a regular routine work or exercise, and looking out of breath, unusually out of breath as compared to other kids. So, and as an adult, if you're having unexplained cough, repeated infections in the throat, repeated wheezing, or breathlessness on, a little more than average exertion, even going upstairs by one floor brings up breathing difficulty. Sometimes these attacks can be more at night. So sometimes some people may become more symptomatic only at night. Sometimes they may become more symptomatic even in a particular environment, in a room, for example, where there may be some dampness in the walls. So there are lots of these things which the parents and the patients who are suffering should be very alert to. And as Dr. Mohan said, the possibility of some inhalant allergens is always high in these cases as a trigger. So they should be away from the trigger as much as possible. Smoking is one of them. Dust, pollution in any form, and smoking, of course. I mean, whether it is smoking or vape, everything should be discouraged anyway. And we also discussed about the usual treatment plan, and sometimes in more aggressive asthmatics, where the disease is very aggressive and brings them to the emergency or even to the ICU, what steps we take. So Dr. Anant has elaborated that beautifully. And sometimes in severe chronic asthma, where the patient is on steroids, oral steroids for long term, you don't want to continue that for life, then you can try immunomodulator drugs, which are the biological agents. So all these possibilities are there. And let me tell you, the life of asthmatics has changed dramatically in the since mid 80s. I did my post graduation in this field in respiratory medicine in mid 70s and late 70s, and we did not have steroid inhalers at that time. So we used to have tablets and tablets, and they act slowly. They cause more side effects, tremors, and palpitation, and sometimes a little feeling, a different type of feeling in the chest. So all those symptoms were pushing us to be very careful with the dosing. And so we were often in a situation where we would not give too much medicine because they were causing too many side effects, and accept some disability on the part of the asthmatics. So that scenario changed in late 80s and 90s. Once the steroid and combination inhalers came, the life of asthmatics has changed dramatically in the last something like 30, 35 years. So we can say that it's much easier to control now than the days we have seen way back. Well, thank you so much, Professor Anand. It's been really pleasure, as always, to have you on the show. Thank you so
Thank you.
much.
Thank you.
And thank you, Rashmi, for conducting yet another very good show.
Thank you so
Thank
much,
you very
Dr.
much.
Dawal. Thank you
My
so much,
pleasure. My
Dr. Mohan.
pleasure.
It was great having both of you with us. Thanks, Akash. Thank you.
Thank you very much. Okay. Good night. Pleasure.
Thank you.